A warm welcome and good evening to all my dears. Today we had completed the ethiopathology, pathophysiology, pathogenesis and clinical features of CS stomach. So that now we have to proceed to investigate the case and to diagnose the same for opt treatment strategies. So let us see how can we proceed to investigate a case of suspected case of CS stomach. After having the case taking from the beginning itself on inspecting your patient, it is clearly noted that our patient is very weak, very emaciated, very exhausted, very cachexic, and he's not having any strength, and he seems to be like that of our drug known as argentin nitricum. That means on seeing a withered, dried up, old looking man, always think of argentin nitricum. The symptoms are something like that. Here our patient is also seems to be like that. He's older than actually what he is, and he's very cachexic also. As we mentioned earlier, the tumor cells diverts disproportionate amount of nutrients or energy or vitamins, etc. simply to the growth of the tumor. That is why our patient become very lean, very emaciated and very cachexic and very anemic also. Next, about our patient always wants to lie down because he is not having that much strength. He always seems to be like that of our symptom of our arsenic alb or acid phos or bacteria or gelsemium, dull, dizzy, drowsy, dimness, something like that symptoms. And next, about on inspecting the abdomen. If the cancer that leads to any intestinal obstruction, say pyloric stenosis, or either smaller or a large intestinal obstruction, in such condition, to overcome the status as an adaptive mechanism, we can see the peristaltic movements. In a normal abdomen, you cannot see any peristaltic waves or peristaltic movements. But at the same time, if the tumor causes obstruction, then you can see a great possibility of observing or inspecting a peristaltic wave. So that is the first line of investigations. Next, about the how can we palpate the abdomen. A palpable abdominal mass with a regional lymph extension. That means involvement of the regional lymph nodes can be seen, especially to the left supraclavicular lymph nodes. It is known as Virchow's gland or positive Troisse's sign. It's a very short note. You can expect a short note from this Virchow's gland or positive Troisse's sign. So as the tumor spread from the mucosa to up to the serosa, and from there it perforate and it may disseminate into the lymphatic channels. So the dissemination of the cancer in the lymphatic system usually represented with a positive enlargement of the left supraclavicular lymph node. Here it is here. You can see a left supraclavicular lymph node in a patient with a CS stomach, and it is known as Virchow's gland or positive Troisse's sign. So a palpable abdominal mass with a regional extension and involvement of left supraclavicular lymph nodes, that is Virchow's gland or positive Troisse's sign. And next, about the on palpating the abdomen itself, you can see some periumbilical extension. Periumbilical lymph nodes can be palpated by even by superficial palpation, and if so, it is known as Sister Mary Joseph node. And at the same time, if the extension goes to the ovary or uterine region, then it is known as Krukenberg tumor. And when there is any extension to the, or if you feel a mass in the pre-rectal pouch, it is known as Blumme's shelf. So if the cancer spread or metastasis to the neighboring area, and when it affects the periumbilical lymph node, it is known as Sister Mary Joseph node. And when it affects the palpable ovarian mass, it is known as Krukenberg's tumor. And a mass in the pre-rectal pouch, it is Blumme's shelf. Okay, so after having the inspection and palpation, we can do the special investigations. The usual special investigations are, you know that by having an X-ray with barium sulfate, that is double contrast barium meal or double contrast barium enema can be used accordingly. And very sensitive and very specific investigation can be made on by using endoscopical examinations. And to know the stage or spread of the spread of the CA, we can have the CT examinations. Then by doing the PET scan, positron emission tomographic scanning. By using the PET scan, we can study the possibilities of metastasis in distant areas. And by doing MRI and with the biopsy, etc., we can pinpoint and we can do a very sharp diagnosis. And on examination of with a barium meal, that means if your stomach is a very normal homogeneous consistency, the barium will completely fill in the stomach through the passage of the barium meal. But at the same time, due to ulcer crater or due to fibrosis, there may be some distortion of the shape, distortion of the size, and the size and shape of the stomach will be very distorted, and the size will be especially in infiltrative variety. You can see our stomach will converted into a very small, thick, corrugated organ, and like that at the same time, in case of fibrosis, there may be some filling defects can be seen. So by using the double contrast barium enema or barium meal, you can see the defect in the size and shape. It is the ulcer crater and distorted shape of our stomach, etc., can be seen in this X-ray is with the pyloric obstruction, and here mass causing ulceration, ulcer crater. It is the ulcer crater. So by doing the barium meal with serial X-rays, we can know the filling defect, the degree of inflammation, degree of pathology can be evaluated by the barium meal X-ray. So by doing the double contrast barium enema or double contrast barium meal, 90 to 95% of sensitivity can be studied by doing the same. If, the basic of the double contrast barium meal is defect in the filling, that is filling defect, especially in the infiltrative variety of the stomach appears, and especially in infiltrative variety, the stomach lost its normal shape and size, and finally the stomach will convert it into a very rigid, a very narrowed tube-like structure, a very rigid tube through which the barium may pass instantly. And next about the endoscopical examination. As you know, by doing the endoscopical examination, we can observe the area, we can study the area, and at the same time by the same endoscopical machine or instrument, we can have the multiple biopsies or breast cytology, etc. can be do with the same endoscope. So diagnostic endoscopy plays great important role in the investigation, management and treatment with the diagnosis of the possibility of cancer. So it has the highest sensitivity and specificity, and we can localize the primary tumors and ability to perform biopsies, and by endoscopical breast cytology or by doing multiple biopsies provide 100% diagnosis. So without having much damage to the patient, we can have multiple biopsies from suspected areas or different areas of stomach, and by that we can study the histological peculiarity. So endoscope plays great important role. At the same time, nowadays the endoscopes are equipped with ultrasonology also. So ultrasonological endoscope also used along with the previous endoscopes. And here by using the ultrasound, the sensitivity and susceptibility will increase, and involvement of the lymph nodes can be studied in a very nice manner. Biopsy, you know that. And next about the CT scan. As you know that more than that of our X-rays, the X-rays are basically dependent on the tissue density. But at the same time, if X-ray is having its own limitation. That means the X-ray can pass only in a single plane, either anteroposterior or lateral or posterior anterior, something like that. But at the same time, by using the CT machine, we can use the very purified form of X-rays, and we can control the quantity of the X-rays emission, and more than that, we can drive the CT machine in 360-degree angles, and we can get the data of a sliced manner within a range of 2 to 5 millimeters of mercury, so that we will get a maximum data by using the CT of our patient. The CT to find out the by using the CT we can stage the, or we can study the spread of the tumor, and we can study the prognosis of the course of the disease, whether it is going good or bad, something like that. To find CT is usually used to find out the staging and spreading, and it is also used we can use the CT especially in suspected case. That means the early detection, either by doing the ultrasonology or endoscope, or by doing barium mill, we may not get a positive result. But at the same time, the early detection, the timely detection of the possibility of CA can be studied by using the CT machines. And it is very highly sensitive for metastatic lesions also, like that of a PET scan. And there is a great possibility, but at the same time there is a possibility of missing lesion. That means if the size of the lesion is less than 5 millimeter, there may be a lack of possibility of diagnosis. But at the same time, nowadays we can study the presence of lesion even though the size of the lesion is less than 2 millimeter. That much sensitive CT machines are now available in market. And next about the PET scan, that you know that the PET scan it is nothing but the positron emission tomographic scan, and by that we can study the degree of metastasis in very distant areas. All body PET scan will reveal the data of the same. And next about diagnosis can be made by the laparoscopical examinations also. Direct, it is nothing but the direct visualization of the part of the CA. And next about the complication, you know that, excuse me, regarding the complication due to the spread of tumor or due to the involvement of various layers of our stomach or neighboring viscera, it can pierce the blood vessels also. So there is a great possibility of profuse hemorrhage. The profuse hemorrhage may be presented as either as melena or as hematemesis. So there is a great possibility of profuse hemorrhage, and thereby leading severe anemia, may be the PC. And the ulcer can, or sorry, the cancer can perforate the primary lesions, primary site from the distant areas, and it can penetrate. And as we mentioned earlier, when the CA or when the tumor that affects the upper portion of the stomach or the lower end of the esophagus, then our patient will have the complications with dysphagia. And when it affects the pyloric portion, that means fixed narrowing of the pylorus, that will leads to gastric outlet obstruction, and projectile vomiting may be the problem. And one of the main complication of, or the most probable complication of our CA stomach is metastasis of the cancer to the neighboring viscera or very distant areas of our body, and thereby it can affect and involve the multi-system. Mostly the CA affects the hepatobiliary system, particularly the liver, then to the pancreas, and then to the small intestine. And it can, by bloodstream, it can affect the lungs or bones or anywhere in our body. And next about the, it is with the complications. And regarding the management, as you know, as the pathology advances, our patient become very naturally very anemic, very exhausted, very cachexic, loss of strength, loss of weight. In such condition, we have to, our aim of treatment or aim of management is to improve the, or we have to restoration of fluid or restoration of blood, or blood transfusion may be essential, especially in very severe anemic patients. And correction of sodium potassium balance and blood transfusion, and we have to improve the nutrition and give supplements with adequate vitamins also. So multi-level management is necessary in patient with CA stomach, and depends on, in some of our patients may be very anemic, in such patient blood transfusion may be needed, and in some other patients the electrolyte imbalance can be seen. In such patients the electrolyte balance has to be opted. Then due to very severe anemia or severe hypervitaminosis, we have to improve the nutrition and give supplement of adequate vitamins also plays great important role. And regarding the DD of, usually the DD of CA stomach can be made with a CA cecum, then CA pancreas, pernicious anemia, and uremia. And next about the surgical treatment. When the medicinal treatment fail, or there is no scope of medicinal treatment, in such condition surgical manipulation may be needed in patient with CA stomach. And the usual procedure to do the surgical treatment with a total resection of the stomach, that is total gastrectomy, or any portion or a small portion of the stomach may be removed, that is a subtotal gastrectomy. And if there is possibility of metastasis, resection of the regional lymph nodes. These are the surgical protocol in CA stomach. It is a subtotal gastrectomy. A small portion of the stomach may be removed. It is the subtotal, and it is the total gastrectomy. That means the stomach is totally removed, and anastomosis can be made by the esophagus and the small intestine directly. So it is built out to operation, and all those things are well studied in your subject with the Department of Surgery. And finally, thank you for watching. Thank you, dear.